present this topic, which is probably important for your exams. But yeah, let's start it. So, Sabha sir told me to present about cortical-sparing adrenalectomy. Cortical-sparing adrenalectomy it doesn't have too many things, so I thought I'll just include a few more topics along with that. So it's coming with, I'm sure most of you all know all of this, but yeah, just to revise so that will be helpful for your exams. I'll be talking about adrenalectomy, its complications, cortical-sparing adrenalectomy, and also thyroglobulin surgery. So the structures that are in close relationship to each of the adrenal glands that we need to be careful of when we are doing these adrenalectomies are on either sides, as we all know, right and left sides. Different parts, different types of organs involved, and complications associated with each of these adrenalectomies is different. The right adrenal, right kidney and ureter, liver, duodenum, large bowel, diaphragm, and inferior vena cava. On the left side, it is left kidney and left ureter, spleen, tail of pancreas, large bowel, stomach, diaphragm, and the aorta. So preoperatively, what you need to make sure all these patients are being prepared with is definitely incentive spirometer. That is compulsively more important for open adrenalectomies, but also required for laparoscopic adrenalectomies. Retroperitoneoscopic adrenalectomies may not so very particular, but definitely for open and lap, they need to do incentive spirometer. We teach them preoperatively so that postoperatively they know how to go about with this. TED stockings for DVT prophylaxis. TED stockings definitely for all of our patients. DVT prophylaxis we give especially for Cushing syndrome and in adrenocortical carcinomas. For most of our other patients, such as POs or Cons adenomas, we don't recommend a routine injectable thromboprophylaxis, but that's test stockings all of these patients get. Intraoperatively, what you can use is sequential compression devices, and the other preoperative preparation, that is a special case scenario, is in pheochromocytomas where salt and water loading is required. The indications for adrenalectomy are for malignant lesions. Depending on what the size of the tumor is, you decide whether you're going to do a transperitoneal, retroperitoneal, or a retroperitoneoscopic, or a lap or an open transperitoneal operation. Also for functional tumors and for metastasis. Here you can see a young boy with gynecomastia, round faces. He was a patient who had right-sided cortical Cushing's adenoma, and we operated him. This is another large lesion. He underwent, as you can see, this is a postoperative picture. There you can see these port sites, and he underwent a right transperitoneal and laparoscopic adrenalectomy. This is another large lesion which turned out to be an adrenal oncocyte neoplasm. We did an open adrenalectomy for this patient. So the types of adrenal operations can be divided broadly. This is good to write for your exams. Types of adrenal operations can be divided into transperitoneal and retroperitoneal. Transperitoneal will be open, laparoscopic, or robotic. Retroperitoneal can also be open, laparoscopic, and robotic. So this is, as you can see, this is the transperitoneal procedure where you can see your open operation being done. This is your laparoscopic transperitoneal operation where you can see 3 or 4 ports. Right side, we prefer to put 4 ports for liver retraction. Left side, 3 ports first, and the 4th port if required for spleen retraction. And this is your retroperitoneoscopic approach, wherein we've seen the next picture. Yeah. Okay. Okay. I'll just come to that. Yeah. So this is your retroperitoneoscopic approach, wherein you can see the patient in a prone position with the hip flexed and the knees flexed, and then we go from the back. Just to see how many of you are actually attending this, what is the acronym which is used? What you can do is you can go to, if you can scan this and see if you can answer this poll that I put up. Let's see how many of you are actually attending this and paying some attention to this. What is the acronym used for posterior approach simultaneous bilateral adrenalectomy? Just go to Google. Yeah. Are you able to scan this and go on to poll and give a response? Yes. Yeah, Cobra is one. Somebody has put COPRA. Cobra is the other one. Yeah, so COBRA is what is the acronym that we follow here? That is combined bilateral retroperitoneoscopic adrenalectomy. That is bilateral retroperitoneoscopically. we do at the same time for pheochromocytomas or for Cushing's. Cushing's we avoid doing a cobra operation, but for bilateral pheochromocytomas, combined bilateral retroperitoscopic adrenalectomy is the preferred modality to save time and to finish the surgery early quickly. So the open approach is the most invasive approach, has a large incision. Indications are usually tumors which are larger in size. Usual cutoff is about 6 to 10 centimeters. Earlier, we used to believe more than 6 centimeters you cannot do laparoscopic, but yeah, we have done 8, 10, 11 centimeters, depending on what the anatomy is, what is the type of tumor. Definitely, malignancy also open is preferred, but laparoscopically can also be delivered if you are able to make sure that you don't breach capsule and you're able to take out the tumor completely without rupturing the capsule or intra-abdominal spillage. Or for paragangliomas because of the location of the tumor and the difficulty in dissection. Open approach is not desirable when you in patients who have healing problems, such as in older patients or in obese patients or patients who have Cushing syndrome. Open laterectomy or conversion is associated with significantly greater perioperative morbidity, and hence, when possible, do laparoscopy. But there are specific indications for open surgery, and that is what you should follow when the need arises. Laparoscopic adrenalectomy compared with open surgery has fewer postoperative complications, definitely shorter operative time. There is a reduced mean blood loss, reduction in the narcotic requirement because of less pain, and definitely patients can be discharged within a couple of days. Coming to posterior retroperitoneoscopic approach, it provides direct access through the retroperitoneal space, does not require dissection or mobilization of adjacent organs to approach to the adrenal gland and enter into the peritoneal cavity. Bilateral adrenal tumors, patient does not need to be repositioned, and this saves a lot of time and allows direct access to the adrenal glands on both sides. Reduces the risk of surgical complications such as any intestinal injury and postoperative adhesions because you're not getting into the peritoneum. Morbidity that is there is wound infections because there is no, when you have a laparoscopic operation, you have some wound infection, the peritoneum goes and seals. But in a retroperitoneoscopic operation, because there is no peritoneum, there is no momentum there, there is no sealing. So if you have a wound infection in the retroperitoneum, then it becomes really bad. You can have subcostal nerve injury during access, and chronic lumbar pain is another thing that can occur if the nerve gets entered. But the beauty of posterior retroperitoneoscopic operation is the evening of the surgery, the patient will be sitting up in bed. You can make the patient take orally. So it's a beautiful option if done right. Intraoperative complications that you need to remember during adrenalectomy is the left adrenal vein joins the left inferior phrenic vein and directly into the left renal vein. The right vein is significantly shorter and directly enters the inferior vena cava. Length of the right vein and its proximity to the inferior vena cava, there is a major risk of injury and bleeding, and that is what is the problem with the right. So the right adrenal operation is easier because it's right there, but it's a little more riskier because the vein is much shorter and drains directly into the IVC. So you have to get good control before you good exposure and good control before you ligate the right adrenal vein. Loss of control of the vein may result in severe hemorrhage and may require immediate IVC repair because the vein retracts and then it becomes very bloody, and then doing this laparoscopically becomes very difficult. Bowel injury, if recognized intraop, definitely requires surgical repair. If unrecognized, will present with postoperative peritonitis and definitely needs re-exploration. Renal and ureteric injuries are usually rare, but seen in patients with pheochromocytomas, wherein where the tumor goes into the renal hilum, you don't mobilize enough, and you can have injury to the renal and the ureteric ureter, and can present with intraoperative bleeding or urinary leak, and definitely requires surgical management of these complications. Diaphragm and pleural injuries present intra with decrease in ventilation and with pneumothorax and requires a chest tube insertion. Postoperative complications, the perioperative complication rate with any adrenalectomy is about 6 to 18%. Bilateral adrenalectomy has higher complications because both sides operation and longer time of operation, surgeon fatigue, all those things play a role in this, and that ranges from about 23 to 15%. Mortality with adrenalectomy is relatively low, less than 1%. Older age and presence of multiple comorbidities is associated with the occurrence of more postoperative complications, especially patients who present Cushing's for patients who present with adrenal cortical carcinoma. So again, postoperative complications can be divided into immediate and delayed. So immediate is hemorrhage, wound infections, respiratory infections, paralytic ileus, delayed wound healing, pancreatic fistula, DVT. These are all immediate and in the immediate postoperative period. Delayed complications are recurrence of the tumor if it's not completely excised, or if you leave right-sided tumors, if you don't excise it completely, what is called as vena cava trap. Retrocaval trap. So if there is some part of the tumor which is going behind the inferior vena cava, if you're not mobilized enough, you can have recurrence in the retrocaval region, or incisional hernias if you don't close it properly. So risk factors for postoperative complications are patients, as I said, with higher AST score or diabetes, obese patients, tumor size which are larger, Pheochromocytoma and malignant adrenal lesions, and when you convert from lap to open, these have higher risk for postoperative complications. This is one of our initial patients who was medullary thyroid cancer, had very high levels of calcium, and this is because, and he had bilateral adrenal metastasis. We went in to do bilateral adrenalectomy. He had bilateral bleeds, and this is what it looked like. So hemorrhage is a real problem if you don't, this is a retroperitoneoscopic operation, then we had to re-explore him. We went again retroperitoneoscopically, and we managed to evacuate the hematoma and clip whatever was bleeding. Clinical features will be tachycardia, hypotension like all hemorrhages, hemoglobin monitoring, CCT to see what the bleeding is from, where the bleeding is from. You can try to coil it, or embolization can also be attempted. If patient is hemodynamically stable, can stop with observation because it's in the retroperitoneum, usually stops. If it continues to bleed, may require coiling or embolization. If it is hemodynamically unstable, needs definite exploration and control of the bleeding. Infections can be surgical site, deep space infections, or respiratory infections. Surgical site infection needs drainage and antibiotics, especially in case of Cushing's, which have a high risk of infections. Deep space infections, drain placement and antibiotic should do. Respiratory infections, all patients should have aggressive chest physiotherapy, incentive spiro, and early ambulation. Cushing syndrome, as I was saying, is something that requires special attention, and because of the high steroid level which is circulating, anti-inflammatory and immunosuppressive effects of the cortisol is present in Cushing's, and this increases the risk of postoperative infections. Also, there is an inhibition of collagen synthesis and increased blood coagulability, resulting in poor wound healing, DVT, and pulmonary embolism. So DVT occurs because of high cortisol levels and prolonged immobilization, and this is prevented by tight stockings, sequential compression devices, and injectable thromboprophylaxis. So our policy is one shot before the operation, and within after 24 hours. Depends on how bad the Cushing's is. Either the 12 hours post surgery or 24 hours post surgery. Once all your bleeding risks have subsided, then you give the next shot of injectable thromboprophylaxis. Pancreatic fistula is usually seen only when there is a large left-sided tumor which is close to the pancreas. Treatment is, if drain is in place, wait for spontaneous regression. It may take a few weeks to months. If imaging shows any intraabdominal collection, then you may require a percutaneous drain placement. Delayed complications, as I said, if not completely excised in the first operation, especially when on the right side, when you have tumors which go behind the IVC, which is called as a retrocaval trap. Rarely incisional hernias, that's because of improper closure of wound infection, and this may require a mesh. So as I said, adrenalectomy is a challenging procedure which requires adequate exposure, meticulous vascular control, and precise dissection of the gland and the tumor. Benign, functional or non-functional adrenal tumors, preferred modality is laparoscopy. Can be either retroperitoneoscopic or transperitoneal. Malignant or suspicious adrenal masses, preferred modality is if expertise is less, then open adrenalectomy or laparoscopic adrenalectomy can also be attempted. Bilateral adrenalectomy, retroperitoneoscopic adrenalectomy is a preferred modality and saves a lot of time because you don't have positioning. Two teams can operate together. Is a beautiful operation.